Good afternoon, everyone. I am Ashwini Chhatre. I am a professor of public policy at the Indian School of Business. I also serve as the director of the Bharati Institute of Public Policy.
I'm Sarang. I'm associate professor in the operations management area at the Indian School of Business, and I serve as the executive director for the Max Institute of Healthcare Management.
Thank you, Sarang. Today, we are going to talk about strategies for addressing public health challenges in general, but with a specific focus on the unfolding epidemic. Today, at least so far as we can tell, cases in India have passed the 200 mark. And a lot of discussion is going on about the possible consequences of both action and inaction. We would like to take this opportunity to talk about some of these options and possibilities from the point of view of tackling the crisis. Sarang, could you give us a brief introduction to where we are and what might be, let's say, three questions that would be of great interest?
Sure. So, as you said, Ashwini, today we have crossed the 200 mark in terms of the number of COVID-19 cases, and we've registered 5 deaths. Of course, 20 cases odd have recovered from the COVID-19 infection. A lot of people believe that we are entering, as they call, or possibly entering stage 3 of the epidemic from stage 2, and I think that's the main source of uncertainty or concern. Stage 2 implies that the transmission of the epidemic is still happening in pockets, whereas stage 3 would mean a community transmission scenario where if I get infected, I really cannot trace back my infection to a particular person. So it's out there, which is the concerning scenario, right? Now, government is of course very aware of this situation and is trying to take a lot of efforts. They've been lauded by a lot of people, including the WHO country representative. But there have also been questions/concerns on the contrary, whether this is the best approach. So I think it's good to just lay out what the approach currently is, right? There are two parts to this, right? So first, the overall approach is guided or informed by the fact that most of the infections are coming from outside, right? So what we may call as imported cases, and that's a valid assumption to start with. So specific attention has to be paid to people who are traveling internationally and identifying which of these people have the infection. You can know about this only if you test people. So then the next question becomes, what is my testing strategy or testing approach as a part of the overall strategy to contain the epidemic, right? So you start with this core of international travelers, and if they have symptoms which are fairly generic, they are flu-like symptoms confusing with cold and cough at times, etc., right? But if you're an international traveler and you have the symptoms, then you get tested. Now the question is, where do you get tested? So as it stands, until 2 days ago, you could get tested only only for a large country like India, 50 labs, which are government labs, right? With all the checks and balances and accreditation, etc. And then this was expanded to a set of roughly 120 labs, government labs. And there is now a proposal to include private sector labs that are accredited under the NABL, National Accreditation Board for Labs, etc. So there's a certification involved. So that's the infrastructure that we have for testing. Now the eligibility for test.
Yeah. This is the infrastructure that we have chosen to use for testing so far.
Absolutely. Right? And so, as you can imagine, it's natural for the government, public health system, as you know, just as a backup, right? India has a mixed health system, which is public and private. And the government plays 3 roles in healthcare: providing healthcare, paying for healthcare or spending on healthcare, and regulating healthcare. And all these 3 roles can get mixed at times. And this is actually a good example of that, where the government is coming up with rules and regulations of who to test, how to test, using their own physical infrastructure to test, and obviously paying, right? And as we go forward in the discussion, we should talk about how to expand this, or whether even
Who
it
gets
makes sense
tested?
to expand both who gets tested and where they get tested, and then who pays for it. And if you don't expand in a particular fashion, what may be the consequences of not doing so. So coming back then, so the current eligibility is, as I said, international travelers with symptoms. If you happen to be a close contact of an international traveler, you don't get tested. If you're a close contact of someone who has the disease, is a known case, you don't get tested unless you develop symptoms, until you develop symptoms. And of course, people have been using other extreme examples of benchmarks as South Korea, where you have drive-by testing centers and people are getting tested at, intersections of streets and signals, etc. The question is, do you want to go that far? And are there interim stops, stages of expanding the testing eligibility criteria? Yeah.
So, in other words, there are two extremes. India is somewhere in the middle towards the lower end, and there is a lot of questions, or at least discussion, around India's testing strategy. And the testing strategy that you just described incorporates at least three dimensions. One is the determination of who is to be tested, and the institutions involved in making that determination, which is absolutely crucial for containing the epidemic. We need to determine how many people are detected. That allows us to make an estimate of how many undetected cases there might be in the population. The second part of it is who does the detecting, and the first 50 labs, then 125 labs, potentially 200 labs, but certainly not street corners and drive-through testing as one extreme. So that's the second part. And the third part there that I see as equally important is the opportunities that this provides on multiple dimensions. We may not, I think we should choose to focus for this conversation on the public health challenges, the ways in which our existing institutions were prepared for the pandemic, and the ways in which they were not and could be improved.
Sure. No, absolutely. So those are good points to talk about. You correctly said that India falls somewhere in between in terms of their testing approach when you compare India with other countries. I would say in between, yes, but on the very much on the lower side. The numbers being thrown around are, we are currently testing 5 people per million, as against South Korea, which is 5,000 per million. Now again, the premise of that, so if you go back to the guidance that is given by the Indian Council for Medical Research on their testing strategy, is the goal of testing is to contain the epidemic. So, generally, why do we test people? So that we can find who has the disease and treat them, generally, right? But in a case like this, you also want to test people because then you can use that to stop the transmission from happening, correct? So that's a valid criteria. The second and kind of important but interesting criteria is, they're saying that we do not want to choose a testing strategy that leads to a panic-like situation and people scampering to get tests and going all over the place and creating chaos, right?
And possibly increasing transmission.
And increasing transmission in crowded areas. I mean, we all know the number of stampedes that can happen in crowded places like India, and now with the transmission thing. So, the question is, if you wanted to contain the epidemic, take an extreme example, do you even need to test? You can just ask, you just put curfew everywhere and have people not get out of their houses completely. And we are going to pilot that on Sunday, as the Prime Minister announced yesterday, correct? So we can see this is an alternate approach, right? Now, why do we then think that we need to test and expand testing to some extent is because full shutdown is not possible, is costly, has economic consequences, has social, psychological consequences. So the goal is to balance, keep the society, economy going to some extent, and yet being able to find those cases. So now here is a good time to look at some parallels. So if you look at the TB world, tuberculosis, which is also a sort of
Highly
infectious
contagious.
disease. It transmits through droplets, air, etc. Right? India's strategy there is test and treat. Right? So why does testing help? Because once I test and I find someone has TB, it is in the national control programs guidelines to do contact tracing. Right? So I can then trace the contacts and test them for TB. Right? So my point is, between where we are now in terms of COVID testing strategy in India and where South Korea is, there are a lot of intermediate stages that we can go to. And the reason we can go to that, fortunately, at least now, is because there are estimates that currently we are using only 10% of the testing capacity. And as you said earlier, within the network of labs that currently are doing testing, mostly in the government sector, public sector, right? So the question is, rather than saying that the current testing strategy is not appropriate or not good, which a lot of people are saying, I think the next level of question is, what is the alternate? What are the eligibility criteria that will take me from 10% utilization of capacity to 20, 30, 50, 70, 80? And this is non-trivial, because if you relax it too much, you can go from 80 to 200 suddenly, and that is where the problem will arise. So this has to be sort of done with a scalpel rather than a hacksaw. So that, I think, is something that people are just beginning to talk about, but may require some evidence base.
We already have a lot of evidence. We know what are the most vulnerable demographics. So that is the, I would say, most obvious next step. We know where the capacity is. So that is the most obvious next step. And we also have the surveillance and payment infrastructure to make sure that these tests are documented so that we know, and we can use the data from those results to sort of generate estimates of transmission and the development of the epidemic. So I think the evidence already exists, but does the institutional framework exist to make this possible?
So it's good that you bring up the topic of surveillance, Ashwini. Now, testing, the way we've talked about it so far, is obviously different from surveillance. The notion in surveillance is that I'm keeping a tab, whereas testing is something very pointed, right? India has a program called IDSP, Integrated Disease Surveillance Program, and it is well known that it is severely underfunded compared to even other public health programs which themselves are underfunded, right? Now, a great strategy in this kind of a scenario for COVID would be to leverage what we call as the network of influenza-like illnesses surveillance, right? Because the symptoms are so similar, which already exists, right? Now, how strong it is, what is the quality and quantity of data collected, how is that process, what insights are generated every year. We don't talk about it as much as against, let's say, Western Europe or US, because they have a seasonal flu epidemic and it's like ebb and flow of every year, right? Just like people keep track of sporting calendar, they would keep track of these things and design strategies. Whereas in India, flu is sort of, always in the back end. So that, having said that, now, why is that relevant to our testing conversation, right? The whole testing strategy currently is based on the premise that we are in that stage 2. How do I know that I've gone into stage 3? So if I don't test in the community at all, I would not know that there is community transmission, unless by accident it so happens that I test someone and is COVID positive, and then I cannot trace back that person to a known case, right? So then what is the proactive way to keep checking for community transmission? Current approach that ICMR has is going into ICUs, hospital ICUs, looking for patients who are admitted there with a severe sort of respiratory problem, correct? Because again, that is a known complication of COVID. So if I look at those people and then test them and say how many of those have the coronavirus, then I start to get a sense. Now, the epidemic is so, or the pandemic is so quickly evolving. Imagine if I go to the ICUs today, who are the people who were admitted in the ICU 10 or 15 days ago? And so every picture that I'm capturing today is a picture of 15 days ago, right?
It's 2 weeks too old.
Exactly. And what ICMR has done so far is said we have sent out 1,000 samples in the entire country once to 20, I think 50 labs, 20 each, right? They are now beginning to convert that into a routine surveillance program, but still focused on the ICU. So even today, that program is not explicitly laid out. What we hear is 1,000 samples have been tested, right? But is it 100 every day that you will send out for the next n number of weeks? From where are you collecting them? So which kind of hospitals are these? Are these hospitals located in the hotspots of the COVID-19 pandemic?
They're all over.
They're all over, right? So we know if it's coming from international travelers, we know the pockets, right, where people first come. And so if you oversample those, see, the whole point is we need to be able to run fast and try to catch the epidemic. And so looking at places where the epidemic is most likely to be and spending all the energies there will give us more returns.
So is it possible that ICMR is not the right institution for this? And that, I mean, I look at the comparison to the Centers for Disease Control, and their job is disease surveillance. They are the ones who keep tag on the flu epidemic, make sure that the vaccines are in production 6 months in advance of the flu season. They track Twitter feeds to assess geographic spread or hotspots. ICMR does mostly clinical research, excellent research, very important research, but they don't have the capacity to do things in real time. They, I mean, like researchers, they need time and they need space in order to do a good job. And this is not a time for sort of laid back activity.
No, I think there is something here. So as the name even suggests, Indian Council for Medical Research, what we want, and probably there are people coming out of the woodwork as we speak, is specialists in infectious diseases for this specific pandemic, but also people who know how to manage large-scale programs of public health. Right. Again, given my experience with TB, work that I've been doing personally for the past 5-6 years in terms of research in TB management programs. In the initial days, the examples that were used were about, hey, how did we manage polio, right? How did we eradicate it? So there was a management structure, there was leadership, there was vision.
There was funding.
Right? And then similarly, people talk about leprosy, right? Because leprosy had a program and a management. The question is, do we need to, because you can't come up with that management structure now as the situation is evolving. So what can we do to strengthen that management? And it is very well known that the Indian health system is siloed. Each of these disease programs are verticals and they perform very well, but there is no COVID program, correct, which has been running for 30 years. So how can you use the existing structure but create these connections? Because as we just said, if I want to keep tab on COVID, I need to have the influenza-like illness network that I can tap into, correct? Or as we are just finding out, there was a news from Rajasthan that the person who was treated successfully for COVID was treated using HIV drugs. So now if, let's say, I have to start treating many more patients, I need to have a connection with the HIV program because the drugs and malaria, for example. Malaria drugs are useful. So these interconnection between programs which doesn't exist today, both for surveillance, but also management and treatment. I think those need to come up, and lessons from this experience hopefully will be useful in the future.
And it is something that we can use to build from what we already have. So clearly, the tuberculosis program, the leprosy program, I think even the AIDS control program, because there are
Yes.
transmission vectors
Yes.
that were effectively contained
Yes.
through management
Correct.
and not just treatment.
Correct.
There is a lot of experience within India and expertise that can be leveraged, but is currently not on board simply because we are in an epidemic situation. And of course, there are always lessons to be learned, and hindsight is 2020. Is there something that the private sector can bring to the table in an ongoing epidemic? What can the government do to
Yeah.
get more help from the private sector?
Yeah, and this is one of the recurring points of discussion in Indian healthcare system, because there are two schools of thought which are seemingly very disparate. The classic public health approach, we have been for a long time a socialist economy, and so there was a belief that everything can be done in the public health system. Only when you look at the reality, you realize that 70 to 80% of the care actually is provided and sought in the private sector, right? So the private sector, on the other hand, is, profit making to a large extent. There are few non-profit entities. So there is a, separation of worldviews, and becomes hard to combine the two. Now, you talked about experiences from other contexts, and so here I think the TB experience is quite helpful. For years and years, the TB program tried unsuccessfully to work with private practitioners. And one of the reasons for that, which again in hindsight is 2020 and clear, is it was based on the premise. So the strategy was, a private doctor once identifies the TB patient, refers the TB patient to the public program, and the public program will take care of that patient. Now, we all know this. No private doctor is going to do this, right? No, is going to give away the patient, despite saying that, oh, TB typically occurs in low middle income segments and there's not much money involved, but this is not
This is
done.
not how doctors work,
Right?
or the business works.
Correct. So the switch that happened a few years ago, and this is well documented in the National Strategic Plan for TB, is that we will not do this referral mechanism, but we as a national TB program will upskill the private providers and engage with them actively so that they can manage their TB patients better, more effectively, and we can provide support services to them, right? So this is, truly moving into partnership engagement mode. Now, to do this, I need a lot of paraphernalia. So as we said, it's a test and treat regime in TB. So now, where do you test? Because initially patients were referred to public program, public labs can test. So then you had to create an infrastructure of private labs to do the testing. Testing in private labs is expensive. So the new TB tests that have come out and our WHO endos are expensive. So how do you bring down the cost there? So then there was a consortium developed that then worked with the manufacturer to bring
Negotiated
down
prices.
negotiated prices, work through the value chain and reduce margins or manage margins to convert a low volume business into a high volume, low margin business. But this is, where we talk about management going beyond the technical aspects, clinical parts and the technical parts. And I think this is pertinent because now there is discussion that for COVID-19, why do we want to restrict ourselves to only 100 odd labs in the public sector and involve the larger private sector labs? So again, correctly so, right? The response so far is yes, but we will only allow NABL accredited labs. Fine, but that's only a technical criteria. Now, how do you integrate these labs better from a management perspective, right? So the data that gets collected there, will they take public health action? Meaning, if they find a positive case, will they do the contact tracing, right? Labs, if they can't do the contact tracing, typically labs are affiliated with hospitals. So could there be training of a cadre of workers? And there are a lot of people, but that they have to be galvanized. There are a lot of
And
NGOs that
empowered.
would be empowered and given the necessary tools. I think that is the next step that we need to think, because it's not only about a sample being tested, but a backup action to be taken on the basis of the result of the test. Yes, so there
So
are lessons to be learned.
if today someone has no reason to believe they are exposed to the coronavirus and they start showing, they become symptomatic in some form, fever, cold, sneezing, running nose, sore throat, some bunch of regular usual suspects, the current advice is not to test but wait. Right? I believe that is sound advice. And if it becomes worse or doesn't go away, doesn't flatten, doesn't recede in a few days, then seek testing. That is in combination with social distancing, the primary strategy for reducing the impact on the public health infrastructure. Right? Assuming that the number of cases are going to go up, that the trend that we see in every country is that right now it seems to me, back of the envelope, cases are doubling every week. Assuming that that trend is not going to change, sooner or later we have a hard constraint on who can test that is going to bump up against it. So how much time do you think we have before we galvanize this system and bring more players into?
So let me give you some numbers. And now we're talking about bringing private players not only in testing, but probably in helping to manage the fallout. So isolate, or let's say if you get cases, then put them under ICU or some treatment care, right? There are estimated to be 70,000 ICU beds in India. Now, like a lot of healthcare data in India, who knows where it comes from, how much is the validity. But let's take that as on the face of it as given. It is unlikely that all these 70,000 ICU beds are in hospitals that can actually take care of ICU patients, right? Beds are beds. So if you apply a very generous fraction to it and say maybe half of them are in a good position, right? So that's 35,000. You can't use all the ICU beds for COVID.
There are other non-COVID patients.
Right. So that brings down the number further, right? Now, this is the supply.
So just hold that thought, but the limiting constraint may not be beds. The limiting constraint may be respirators.
Could be ventilators, could be nurses, could be the intensivists. I mean, if you talk to patients in India, they don't even know intensivist. They know the doctor. But that there is a specialty. So that's in, and possibly digital technology can help. There are these remote ICU management solutions that exist. But again, you can't ramp them up immediately, right? So even if you took simplistic view of beds, and which I agree is limiting, compare that, so that's the supply, compare that with the demand, right? So who is typically going to get admitted in the ICU because of COVID? Elderly. And we talk about our population being very young, which is correct. So elderly by various definitions would be some 8% of India's population. But 8% of India's population is huge. Right, it is millions, and we also know that 5% of COVID cases are serious, right? So now if you put the math together, which I don't want to do here on the fly, but it means severe,
500,000 people.
Yeah, severe constraints, correct? So then I think you need to link these two, which is our testing strategy currently aligned with the treatment and care capacity that we have downstream? Because it is possible that if I'm able to detect cases earlier, especially in the elderly, I may be able to treat them before I need to put them in the ICU, at least a fraction of them. right?
Yeah.
And this is again different from the international discourse, which, so there's a very good study that has come out of Imperial that talks about millions of people dying in the US if, the epidemic is uncontained, and similarly in UK, 250,000 people, etc. They don't too much talk about the critical care capacity because relative to India, they have a lot, correct? But in India, the testing strategy itself may have to be geared in such a way that I can detect faster and
And
contain.
and target the more vulnerable populations who are going to most likely overwhelm our capacity.
Correct.
So, which brings us back to where we started, our testing strategy. That testing, right now, testing people who are symptomatic is probably erring on the side of what I don't know what is the opposite of caution. It's probably a risky strategy, not because we will not do a good job of identifying people, but that we might be too late in identifying the people who need treatment. And if we want to keep our downstream capacity, especially critical care capacity, in mind, it is extremely important for India to rethink its testing strategy to better target the vulnerable populations.
Absolutely. I would completely agree with that. So tailoring the testing strategy so as to align it with the downstream treatment and care capacity that I have. At the same time, galvanizing, we used this word earlier, empowering and galvanizing the downstream capacity, because you don't want to start thinking about the ICU capacity when you get hundreds of serious cases, right? So again, this is now getting more and more out of the realm of ICMR. And so now I
and
think
their capacity.
yeah, and so now the question is ICMR having discussions already with NHA, which already runs the PMJ program and is a financer of hospitalizations?
Who's going
and
to
so
pay?
are we talking to industry consortiums of private hospitals and say, hey, could you now, we want you to be ready with these many beds and these many people, etc. And because it's a matter of time. I think if we believed, and I don't want to raise any alarms, but if we believe that our cases are going to remain in hundreds, we're living in la la
we're fooling
land,
ourselves,
right?
yeah.
So we have to get ready for it. The question is, as you said earlier, is it 15 days, is it a month, is it 2 months or 3 months? But I think some of those actions can be taken now.
And we can be better prepared than some of the other countries that we see today.
And right now, talk not only about providing care, but paying for care. Right, and luckily we are now in a better position than 2 years ago. Luckily now there is a countrywide mechanism to pay for people's hospitalization. Well, low income people, but sure, I mean, at least they. So can I, create a package that would be needed specifically for this if the existing packages don't cover exactly these type of treatments and hospitalization?
Yes, exactly. We have a payments architecture in place. Individuals are now much better identified because of direct benefit payments and Aadhaar numbers. Hospitals have participated in these health insurance programs, whether by mandate or by choice. And a lot of people have been introduced to the public health tertiary care sector for the first time over the last couple of years. So in that sense, we have made several strides, and if we can ramp up some of our thinking to learn from our own experience in tuberculosis, in leprosy, and so on, bring on board private sector participants, not at the end point for providing care, but at the beginning to think about the financial implications, the preparedness, the training, the infrastructure. We could easily start now preparing for something that is going to happen absolutely, certainly going to happen in 2 weeks or 2 months. And I hope that in 3 months, we will all be looking back and laughing at everything that we were saying and doing. But I would rather laugh than cry.
Absolutely. I hope so too. And I think just for everyone seeing, listening in, all this conversation still, doesn't mean that you can go out and party. You still need to stay at home, uh, practice very good hand hygiene and general distancing. And at the same time, in our individual or professional capacity, try to move the conversation around these issues, as Ashwini said, at the confluence of clinical, operational, and financial considerations, because good public health requires inputs from all three quarters and not just the clinical domain.
Thank you, Sarang. It was a pleasure talking to you.
Thank you, Ashwini.